So I'm here with Margaret Heaton-Ashby. She is a licensed marriage family therapist, and she works with us here at Nevada Advanced Pain Specialists. When I was opening our clinic, I realized that pain had a lot of different aspects to it. And specifically meaning that patients, when they have pain, not only is it a medical problem, but usually it's a physical problem. And then on top of it, it's normal for patients who have those issues then to develop some psychological distress.
Right. Depression and anxiety often go hand in hand with long-term chronic pain.
Yeah, I think I saw some statistic that it was 70% of patients with chronic pain have some type of depression or anxiety disorder. And so a lot of times when patients are exhibiting those symptoms, I try to let them know this is normal, and I expect them to have that.
Right. And so when you refer clients here, it's not because you think they're crazy or that they need to be hospitalized. It's because maybe there's other areas that we can look at to help them live more effectively with pain.
You know, as we're talking about these patients with the depression and anxiety, I realized that if we never address that just treating them from a medical or a physical therapy standpoint, they may not improve. And so that's why I recruited you to come work with us.
And I know when I work with clients a lot, we look at their ineffective pain cycle and how they might be unintentionally increasing their pain levels.
I find it kind of challenging at times that we'll see patients and we're just trying to do what's in their best interest to get them better. Right. And you know, a lot of times we're screening patients to see if they have any, depression or anxiety as a result of their chronic pain. And after we do a standardized test and go over the results with them, and we refer them to you, we find at times that, that they're upset. And I think what they're upset by is they almost think that we are not taking their pain seriously. I think I've gotten better over the years on trying to make that transition and just kind of tell patients that, no, this is normal, what you're experiencing. I would expect you to have this.
Right.
And therefore, that's why I've hired somebody or brought on somebody as part of our team to really help out with these aspects.
Right. And so once you've done your screening and you think that pain psychology or referral to mental health counseling in general would be helpful, when I meet with them, I will sit down and go through their whole life picture. So I do the biopsychosocial again. I look at their social relationships and how pain might be impacting that. I also look at their education history and employment history. We also look at their medical, pain, mental health, substance use history. So I get a whole picture. And oftentimes what I see is pain impacts a number of those areas.
Yeah.
And there's aspects that you can work on, obviously, with the medical side, and there's aspects I can work on with the relationship side, the social side, the mental health side.
Is there a typical patient that you see, or do you feel like there's different categories of patients you see?
There's a handful of clients that I work with where we just look at the pain and how they may be maybe not living as effectively with pain from a behavioral standpoint.
Okay.
Because they might be engaging in what I call the pattern of overdoing. And with overdoing, they do, and push beyond that pain threshold. And the next thing you know, their pain is maxed out, and now they're on that downside, recovering and in lots of pain. And with that, they can be in pain for days to weeks, and then they start to engage in that negative thinking pattern of, oh my goodness, this pain is so terrible, it's never gonna get better, I can't go on like this. And then next thing you know, as they're coming down the backside and starting to feel better days or weeks later, they can't wait to get out and do more, and so they do the same thing over again, and up they go on that roller coaster of doing too much. And that backside is being down and out again.
You're exactly right. I hear several scenarios from patients where, well, like, doc, I went out and I did all this stuff, and then I just laid in bed for 5 to 6 days afterwards. Right. And I guess from my standpoint, I'm always trying to talk to them about pacing.
Right.
And like, you got to learn to do just a few things and spread it out over time versus overdoing things. Is that one of the things you talk to them about, is pacing?
All the time.
And what other strategies do you talk to them to kind of help break that cycle?
One of the other things related to pacing is learning their limits, knowing their limits. Because if you don't know where that limit is for you now with chronic pain, you constantly are breaking it. And so you're constantly re-engaging in that roller coaster of the pain cycle.
Is that just a trial and error thing for them to learn, like what they can or cannot do over time, and have them maybe journal it and write down so they can finally figure out where that line in the sand is to make sure they don't cross it?
Definitely. It's all about just experimenting what works and what doesn't. And of course, pain is different from day to day sometimes. And so it's also just having that awareness that, you know what, I have a higher pain level today, so my limits are going to be a little different. And the other part of that I work with clients on is communicating their limits to their family members, because family members can't read their minds and they don't know where their pain levels are or where their limits are sometimes. And so being able to communicate where that is very helpful.
And so that's one aspect of the patient that you see, or one kind of category, I guess we could say. I'm sure there's another category where patients have emotional distress due to their pain. Would that be a category, or?
Yes, by all means. I know that a lot of people with chronic pain tend to have more depression, more anxiety or fear, along with sometimes more anger. Okay. And all of those are not helpful. When you have more emotions, you have more pain.
Correct.
And so I work with them on relating to their emotions differently, validating their emotions, because pain is depressing. Pain does cause anxiety. It's a valid emotion to have. So when you can validate it, then you can figure out ways to do something that's different than continuing to engage in the same emotional routine, per se.
So you teach them to accept, is that it? To come to acceptance that what they're experiencing is normal, and essentially embrace it?
Yes, definitely. We can look at a variety of different things. First and foremost, we have to help them acknowledge and validate their emotions. And then if they want to break that cycle of emotions, we could look at doing something perhaps that's opposite to emotion. And so if they're struggling with anger, perhaps related to pain, they could do the opposite of anger, which is kindness. And so we talk about them being more kind to themselves, maybe even kind with their pain. And so with that being said, it really creates a different relationship with their emotion, creates a different relationship with their pain. The other one that I really work a lot with is the thinking patterns. So we have some ineffective thinking patterns that make pain worse. The two common ones that I hear a lot are catastrophizing and compare and despair. And so with catastrophizing, I often hear people say, my pain is terrible, it's never going to get any better, this is never going to end, and all of those catastrophic thoughts. The more we focus on our pain, the worse pain gets. And so I help them understand that there's that relationship between our thinking and our pain, and also figure out ways to challenge the fact that, yes, our pain is bad right now, but it's not going to stay at that 8 or 9 level the whole time.
Yeah.
It will go back down, especially if you did that roller coaster that we talked about a minute ago. It will get back down to that baseline pain level. And so if we can figure out ways to distract yourself from your pain when it's high and bad, that's the name of the game, to help us distract our thinking too.
You know, I've heard the saying that distracted patients or distracted pain patients don't have as much pain as patients who aren't distracted. And I guess that would be, personal experience. I know I've had, sports injuries in the past, and it seems like when your mind is on something else than the injury, you don't really think about it. But the moment you stop doing what you're doing, then you start to think about that injury or that pain. And so I think you're right. The power of distraction can really alleviate your pain levels.
Definitely.
Well, the patient who is afraid to move, though, because they're afraid if they overdo it, how do you convince them that they gotta go do something or move around or get involved in some activity in order to alleviate their pain? That's got to be a challenge.
It's a challenge by all means, but we start small, right?
Yeah.
We're not expecting a marathon in a week.
Correct.
We talk about just some basic things they can do at home, or things that they used to really enjoy doing, such as going out to eat, and how we might be able to modify that so it's more doable now.
Yeah.
And also looking at the distraction as well to help with that. So if they can be doing something and talking to a loved one on a phone that brings positive thoughts or positive memories.
It's true. They don't have to be moving at all.
They don't have to be moving at all. Or you can put on some of your favorite music. Another great way to distract yourself. And so there's a variety of different things and strategies you can do to distract yourself and make pain a little bit more tolerable.
And besides catastrophizing, you talked about something else, or you mentioned
compare and despair.
Okay. So what is
Compare
that?
and
What is
despair.
compare and despair?
So compare and despair is when you are constantly in this place of comparing yourself to where you used to be before chronic pain to where you are now. And that's a really depressing thought to have and to be consumed with. And so I hear a lot of clients regularly sharing with me that I used to be able to do this and this and this, and now all I do is this. And so validating, of course, that yes, you used to be able to do a lot more, and now here we are. And so again, it goes back to the acceptance that you had mentioned a while ago, accepting where you are now and acknowledging what you can do, being grateful for what you can do.
Yeah.
Another strategy I like to use for both of these thinking patterns and even emotions is the meditation and the mindfulness.
Okay.
Because with the meditation and the mindfulness, the practice is to, one, be grateful and accept where you are. And then the meditation is just about tuning your attention into your breath. And as you tune your attention into your breath and follow the inhale and the exhale, it takes your mind to the breath rather than to the pain.
Okay.
And so clients often have that ability to just tune out of their pain for a minute and have a break.
Yeah. And then cognitive behavioral therapy. So explain to me about, to me that's trying to break a cycle of thinking. Is my understanding of that correct? Okay.
Very much so. And so cognitive behavioral therapy is just what it says. Cognitive is thinking, so challenging your unhelpful thinking patterns. Behavior is challenging your unhelpful behavior patterns and becoming more effective in living your life.
Yeah. And so kind of what I've always heard is that you have an experience in life that's led to chronic pain. And with that comes thoughts. Thoughts lead to emotions. Emotions lead to actions. And so if you have negative thinking about this injury, that leads to negative emotions that we're discussing, depression, anxiety, which then leads to actions where you do nothing, you feel sorry for yourself, you don't move on with life. Yeah, you isolate. And so I think you're right. You have to, by using cognitive behavioral therapy, you're going to break that cycle. So you're going to teach patients to accept that their condition. You can't change the incident that led to their chronic pain, but you can change their thinking about it. And if you can think more in a positive light, that's going to lead to more happy emotions, I guess is the better way to say it, which then can lead to positive actions. Is that kind of a good way to look at it?
A great way to look at it. And I just had a client recently share with me that in our work together in integrating the cognitive behavioral therapy and the mindfulness, he's been able to engage more with his family.
That's good.
So he's slowed down, and instead of turning inward with his pain and his thinking and his emotions, he's actually said, I'm going to change my behaviors and get out more and engage my family more. And that's also helping me have more realization of the positive things I am contributing to my family, which is changing his thinking patterns and changing his emotions. And so that's it in action right there.
Yeah. Any other type of patient that you typically see, or did we kind of cover the buckets that you see patients when you?
I think we covered most of the buckets. The one thing that I think we haven't really talked about is the social aspect.
Okay.
And how pain can have us withdraw from our community. Yeah. From our social relationships, from our intimate relationships. And so that's another side of that will bring clients in. Okay. For myself to work on.
And social isolation, once again, leads to sitting around at home, increased pain, because they're not distracted.
Correct.
Or if they're more engaged with others or out and about, they can be distracted and have less pain.
Right. And so again, it's looking at modifying behaviors to do things that fit with where they are now with pain, and that they can still get out and engage in life. Yeah. Engage in social relationships, engage in their community.
Yeah. I think it's amazing work that you do. I'm very thankful that we have you. I have to say that there's so much evidence that's growing on how the work that you do impacts chronic pain patients. And I have to say, probably 10, 15 years ago, there wasn't an emphasis on this. It was kind of a a last thought, or, oh, I can't help you from a medical or a physical therapy standpoint, there must be something wrong with you, we'll send you to the chronic pain specialist. And I'm just glad at our clinic here that we don't use it as a last resort. We try to use it up front as a strategy, because if we can't impact a patient from all angles, then we're never going to help them. And if you try one angle and then try another angle, then you're just delaying the inevitable.
Sure.
You need to be comprehensive from the get-go, in my opinion.
I agree. Right. Well, I enjoy being here.
Yeah, well, thank
Yeah.
you.